Welcome to Changes Now Part 4 Workforce, in which we address a wide range of providers, but provide only a high-level overview. There is much more to be learned, but this will orient the learner to the components of the dental workforce in the United States as they exist now in 2022. Here's an overview of what we'll be covering in this presentation. We start out in part one with a high-level view of traditional dental workforce, dentists, hygienists, and assistants. We then move to part two, pediatric dentists, and take a look at their demography and trends in their training and in their composition. Part three takes us to non-traditional dental workforce, specifically dental therapists, community dental health coordinators, and support professionals, social workers, health educators, nutritionists, community health workers, and their role in pediatric dentistry. The critical thing to understand with regards to the traditional as well as the non-traditional dental workforce is that the determination of how those individuals can practice, where they can practice, what they can practice, the scope of practice, the supervision of their practice are all determined individually by each state. Critical dental board issues are then the scope of practice, supervision, educational requirements, and licensure. We'll take a look at dental hygienists and their expanded functions, dental assistants and their expanded functions, keeping in mind that dentists, both generalists and specialists, are typically ultimately responsible for any care delivered by anyone who they supervise. This slide and the following three slides provide an overview of the impact of state regulation on dental professional practice as you consider the different roles that dental hygienists can play as a function of state allowances. Of particular importance to pediatric dentists are the delegable roles of dental hygienists that vary by state with regard to supervision. This slide and the next two indicate for each state as of March 2021, as reported by the American Dental Hygienists Association, the allowable procedures of dental hygienists under different types of supervision. Things get even messier when we talk about the delegable authorities of dental assistants because states vary considerably in whether or not they even regulate dental assistants or whether the dentists simply take full responsibility for any care provided in association with dental assistants during dental treatments. Here we take an overview look at the trends in dentist supply in the U.S. from the American Dental Association's Health Policy Institute, both historical and anticipated. And as you can see, the numbers of dentists per 100,000 continues to increase and is anticipated to continue to increase over the coming decades. Prognosticating the future, though, depends, as you see on the slide on the right, on assumptions made about dental education. The American Dental Association's Health Policy Institute has considered various scenarios as they anticipate the growth of the dental supply in the U.S. Dental specialists comprise approximately 20% of all dentists. That's really quite different than on the medical side, where medical specialists comprise about 80%. Amongst the dental specialists ranked by size, orthodontists are number one, followed by pediatric dentists. Approximately 20% of dental specialists are pediatric dentists. Then oral surgeons, periodontists, endodontists, and down through the list. The numbers of trained dental hygienists exceeds the number who are actively employed as practitioners. With regard to pediatric dentists and dental hygienists, because all but 8 states allow dental assistants to perform coronal polishing, many pediatric dentists in the U.S. do not engage dental hygienists. Whether or not the dental hygienists, however, can provide direct access to preventive dental services varies again by state. 44 states have some form of direct access, the most wide-ranging being Colorado with independent practice, but each state has its own determination of allowances for direct access as defined by the American Dental Hygienists Association. The supply of dental assistants is far greater than the supply of dental hygienists, and dental assistants vary considerably in how they're trained. Can be anything from on-the-job to formal training in public or preparatory schools. Only a small subset, estimated at less than 20%, seek certification by the the Dental Assisting National Board. DANB was established in 1980 to professionalize the field of dental assisting and to set standards for dental assistants. Now let's take a brief look at some trends in the composition of the dentist workforce in the U.S. with regard to gender and racial ethnic composition. What we see is that the proportion of female graduates now exceeds and has since 2019 the proportion of male graduates, leading to the future which by 2040 is anticipated to secure gender parity. We see here that with regard to racial and ethnic mix of dentists, diversity is increasing in dentistry, albeit slowly. If we take a look at the slide on the right, we see that 80%, 79.8%, of dentists in 2005 were white, and that has decreased to 70%. But the increase has primarily been amongst Asian dentists rather than Black and Hispanic dentists. If we take a look at the 2020 figure, we still see that there's a significant discrepancy between the composition of the U.S. population on the right and the composition of dentists on the left, with, for example, 18.4% of the U.S. population being Hispanic, but only 5.9% of dentists being Hispanic, and 12.4% of the U.S. population being Black, while only 3.8% of dentists are Black. As a result of these trends, we see that the U.S. population is 3 times more Black and Hispanic than the U.S. dentist population. On the contrary, U.S. population is only 1/3 as Asian dentists in the U.S. population. Whether this matters is a function of the degree to which dentistry is equitably available. The argument is made that Black and Hispanic dentists are more available to Black and Hispanic communities, and that there's an affinity relationship between populations and their care providers. Thereby, the disparity in the proportion of minority dentists leads to greater inequity in the availability of dental care. With regard to pediatric dentists, half to two-thirds of pediatric dentists are women. According to one demographic assessment, women make up two-thirds of pediatric dentistry. According to the AAPD, it's about 53%, but that includes life retired and affiliated members. As we look at trends over time, we see that the proportion who are female amongst pediatric dentists has continued to increase from 2010 to 2019. And about 10% of pediatric dentists, about the same as the population at large, identify as LGBTQ+. As with all dentists, the proportion of pediatric dentists who are racial ethnic minorities has increased marginally over time, but not dramatically. And the proportion of pediatric dentists by race and ethnicity is about the same as the proportion of all dentists by race and ethnicity. Careful consideration of these statistics on pediatric dentists by age suggests that with the dramatic expansion of pediatric dentistry training programs in recent years, the profession is quite vital with larger and increasing numbers of young dentists entering the specialty. With regard to employment, the vast majority of pediatric dentists, just north of 75%, three-quarters, are engaged in private practice, while a significant number are in education and public practice or safety net practice, with the smallest number involved in government programs. What is most remarkable about pediatric dentistry is the dramatic growth in membership over the years. Since its founding in 1947 to 2022, there has been a steady and regular increase in the proportion of dentists who are pediatric dentists and growth in the numbers of pediatric dentists, as reflected in membership of the American Academy of Pediatric Dentistry. According to a study sponsored by the American Academy of Pediatric Dentistry and published in 2019, the supply of pediatric dentists is growing more rapidly than is the demand, in large part because of the dramatic expansion in training programs. However, this may not be a problem after all, because there are two scenarios under which the supply of pediatric dentists and the demand for pediatric dentists would come into equilibration. One is if it becomes increasingly normative for children to be seen by pediatric dentists rather than general dentists. That is, pediatric dentists capturing a larger share of dental services for children. And the other is if underserved children, who currently are in fact underserved, secure greater access to dental services, demanding greater need for pediatric dentists. And this appears to be the case because pediatric dentists are leaders in providing care to children covered by federal programs, public insurance programs like Medicaid and CHIP. As we now move to non-traditional dental workforce, there's quite an array of activity ongoing at this time. Starting with dental therapists, we will take a close look at dental therapists and how they may interact and relate to pediatric dentistry in particular. Then there are the community dental health coordinators, established by and promoted by the American Dental Association. The engagement of support professionals, nutritionists, social workers, and health educators, who are themselves professionals from fields that don't traditionally address dental care, but have strong potential to do so. And finally, the support of lay workers like community health workers. We'll take a look in detail at each of these. Perhaps the most controversial and the most impactful on pediatric dentistry amongst the non-traditional providers are dental therapists. And we'll start with trying to really understand what they are. And we're going to look first at a definition drafted by advocates for dental therapy. They state dental therapists are mid-level providers similar to physician assistants in medicine. Dentists hire and supervise dental therapists to expand quality care, to more patients, grow their practices, provide treatment to underserved at-risk populations. They can work in traditional dental offices and clinics and community settings, such as schools or nursing homes. Dental therapists provide preventive and routine restorative care, including filling cavities, placing temporary crowns, and extracting badly diseased or loose teeth. So under this definition, it is clear by the advocates that dental therapists are an adjunct to and an expansion of the availability of pediatric services, particularly for underserved populations. And the proponents argue strongly that dental therapists are a needed solution to address disparities in the access and availability and utilization of dental care for underserved populations. Dental therapists, like any dental provider, except dental assistants, are governed by state statute, regulations, and rules. In most states that have already instituted dental therapy, they may provide preventive care, including most of the things that pediatric dentists provide, including intracoronal restoration, stainless steel crowns, space maintainers, pulpotomies, and primary tooth extractions. Dental therapists are the first allied dental personnel since 1913 and the advent of dental hygienists to assume responsibilities that have been traditionally reserved only for licensed dentists. Here's another dental therapist definition from the National Partnership for Dental Therapy, an advocacy group. Take a look at this definition, and then we will come further in this presentation to look at how organized dentistry has responded to the advent of dental therapists. As with any health profession that is regulated by state government, there are a host of issues that determine what a dental therapist can do in practice depending on the state. And as each state enacts consideration of dental therapy, and as those states that have already done so have secured regulations supervising the advent of dental therapy, there's a great deal of variation across those states. Variation in the scope of practice, what dental therapists are allowed to do. Variation in supervision, whether they have to have a dentist present, a dentist available, whether the dentist simply authorizes treatment, doesn't need to be present, or whether the dentist is present or available only through teledentistry or even completely independent. Where and how the dental therapist can be deployed. In some states, there's a strong effort to limit the deployment of dental therapists only to underserved areas. Educational requirements, how much education a person must have prior to enrolling in dental therapy training in order to be licensed in a given state, whether they need to be trained as dental assistants or dental hygienists, for example, or whether they can be trained directly out of high school in a dental therapy training program. While dental therapy has long been established internationally, its advent in the United States has really grown out of a tribal authority for similar medical providers. In the United States, the first advent of tribal authority dental therapists came in Alaska in 2005. That tribal authority, independent of state regulatory authority, has expanded over time, with Washington in 2015, Oregon doing a pilot in 2016, Arizona in 2018, 2019 in Idaho and Montana, and then also in New Mexico. However, the state regulation of dental therapy began in Minnesota in 2009. And as you can see from this chart, now it's Minnesota, Maine, Vermont, Michigan, Connecticut, Nevada, and over a dozen other states and tribal governments are in the process of exploring authorization of dental therapists. So this is a dramatically growing development in the dental workforce in the United States. As with both general dentistry and the dental specialties, the training of dental therapists is determined and overseen by the Commission on Dental Accreditation. The Commission on Dental Accreditation established its first guidelines on dental therapy education in 2013 and adopted them formally in 2015. Required clinical training is specified as it is for dentists. At a minimum, graduates must be competent in providing oral health care within the scope of dental therapy practice, with supervision, again, as defined by the individual states. This slide and the following slide list the specific components of dental therapy training so that graduates of dental therapy programs can, within their states, provide services up to and including this list. As with both general dentistry and the dental specialties, the training of dental therapists is determined and overseen by the Commission on Dental Accreditation. The Commission on Dental Accreditation established its first guidelines on dental therapy education in 2013 and adopted them formally in 2015. Required clinical training is specified as it is for dentists. At a minimum, graduates must be competent in providing oral health care within the scope of dental therapy practice, with supervision, again, as defined by the individual states. This slide and the following slide list the specific components of dental therapy training so that graduates of dental therapy programs can, within their states, provide services up to and including this list. As anticipated, there's been a great deal of controversy around the institution of dental therapists in the United States. Proponents and opponents use very much the same arguments but draw very different conclusions. The proponents claim that dental therapists can expand access and equity without compromising safety, while the opponents state that dental therapists are superfluous and they risk the public's safety while harming dentists' authorities. In this 2018 report from the U.S. Department of Health and Human Services, Treasury and Labor, the federal government has come down with a very strong statement in support of expanding dental therapy in the United States. It claims that emerging healthcare occupations, specifically such as dental therapy, can increase access while driving down costs for consumers while also ensuring safe care. So the federal government's perspective on dental therapy has clearly come down on the side of the proponents. Furthermore, this report suggests that states should now evaluate their regulatory role in determining whether to allow dental therapists and to determine their licensure and scope of practice with an eye toward increasing access and driving down cost while ensuring safety. Not unsurprisingly, the American Dental Association has a very different view about the role of dental therapists in the United States, noting the expansion of the numbers of dentists available to the U.S. public and the anticipated increase in dentist to population ratio, the American Dental Association states that not only is there no evidence that dental therapists can make a difference, but that the data on the increased numbers of dentists available to the public makes the whole idea of dental therapists moot. The federal government does sponsor the training of dentists and dental hygienists, and there's controversy over whether or not the federal government should expand that training support to dental therapists as well. In 2021, 51 advocacy groups petitioned the federal government to provide funding to support the training of dental therapists. By March 2022, nearly 100 organizations joined in that argument. However, at this time, legislation has been secured that prohibits the federal government in providing financial support for the training of dental therapists. The American Academy of Pediatric Dentistry has issued a statement on non-dental provider issues that has not directly stated its acceptance or rejection of dental therapists, but rather reminded the regulators that the dental team should work under the direct supervision of pediatric dentists. The statement does review the literature on dentists' views of dental therapists and notes that the majority of Maryland dentists, Tennessee dentists, and Minnesota dentists, as well as dental faculty, are not in support of dental therapy. At this time, it's important for you to consider what you think, whether you are on the proponent side or the opponent side, whether you see value in engaging with dental therapists in pediatric services, or whether you think that that risks the population's safety and is a problem or an unnecessary fix for a problem that may or may not exist in your mind. So it's important, especially from the role of advocacy, with this hot button issue now underway, for you to consider your own views and decide for yourself how you would like to address the issue of dental therapy in the United States and in your state. There have been many efforts to address disparities in access to oral health services. Those have been political by setting up financing systems like Medicaid and CHIP. They have been organizational like the American Dental Association's promotion of the Community Dental Health Coordinator. This has been around since 2004 when the American Dental Association set up a task force focused on meeting the needs of dentally underserved. By 2006, the Community Dental Health Coordinator pilot program was underway and is now in a much more robust state. There is evidence that the CDHCs work closely with people and families to find appropriate care and that oral health outcomes have been improved. To learn more about the nature of the Community Dental Health Coordinators, we have provided here a couple of links to some videos that provide much more detailed information. So what is a community dental health coordinator? Well, in a sense, they are community health workers, like generic community health workers, who are focused specifically on oral health and access to dental care. According to the American Dental Association, they're trained to work under dentist supervision, to operate within dental practice acts, to address social, environmental, and health literacy issues. As you noted earlier in our presentations, social determinants of health have become paramount in value-based care. And so the Community Dental Health Coordinator is ideally situated to address social determinants, provide effective oral health education, help people identify goals, coordinate care, navigate care, and provide appropriate clinical services. So here's where community health workers and community dental health coordinators differ. Community health workers do not provide any direct services, whereas community dental health coordinators provide some specific services like screenings, fluoride treatments, and radiographs. The idea of the community dental health coordinator is to work to advance advocacy, communication, motivation, address legal and ethical issues, and address financial and payment issues for dental care by helping people access and arrange for their own care. As noted, the difference between a generic community health worker and a CDHC is that CDHCs do provide some direct services. This does put them under the concern and consideration, the purview of state dental boards. So inclusion of these services, depending on the state and its regulations, may require that CDHCs be regulated by state dental boards. The American Dental Association, which created the CDHC, addresses some of the potential roles of CDHCs in reducing anxiety, explaining disease, reducing hospital emergency department visits, improving compliance with home care, helping parents gain greater insight into how to safeguard their children's health, and guide efficient management of oral health issues. In short, what the American Dental Association's position statement says is that CDHCs are well positioned to address the patient holistically and provide wraparound consideration of concerns that lead to oral health or poor oral health by addressing social determinants that include the logistics of accessing dental care. This status report on community dental health coordinators as of 2021 suggests that there are 700 CDHCs graduates now in practice, with another 150 in training, with 20 CDHP programs nationally. 13 states offer in-person training, while 37 states offer online training. So the advent of CDHCs, like the advent of dental therapy, is new and dynamic and growing. Here are some examples from the American Dental Association of the impact of community dental health coordinators on the oral health of populations. To date, there's very little empirical research on the impact of community dental health coordinators. The only analytic report published by 2022 was from the University of Alabama, finding that CDHCs enhanced community relationship building, community-based dental screenings, pediatric dental care coordination, and produced measurable improvements. On the other hand, there's a fair amount of publication that is conceptual or descriptive. One of the advantages of the community dental health coordinator is that they attend to social determinants. On the other hand, there are people who are trained specifically in addressing social determinants, nutritional and dietary determinants, and educational determinants of health more generally. And they might be considered for roles in pediatric dentistry as well, particularly with the advent of value-based care that rewards health outcomes over volume-based care that rewards procedures. There may be ever greater need for expansion beyond community dental health coordinators for the professionals who are trained specifically to address social determinants, behavior, education, diet, and the non-clinical components of oral health attainment and maintenance. Looking first at social workers, we see that social workers focus directly on arranging, coordinating, monitoring, evaluating, advocating services that meet a client's complex needs. So it takes the issues of oral health determinants well beyond the dental office. With regard to the engagement of social workers in pediatric dentistry, we welcome you to visit a website and video that is indicated at the bottom of this slide. All of us health professionals consider ourselves, at least to some degree, to be health educators. And the literature suggests that dentists and dental hygienists are really quite good at educating their patients, but not necessarily as good in helping families adopt and change behaviors that are important to their children's oral health. In 2008, the field of health education became formalized with the institution of the designation of a certified health education specialist. Health educators, people who are in the professions and involved in health education, can sit for the CHES examination and become certified health education specialists. So those would include healthcare providers, including us dentists, as well as people who have the academic background in health education to meet the qualifications to sit for the examination. Certified health education specialists are responsible for setting up and managing various programs at both the individual and community level to help people adapt their behaviors and adopt strong, positive, salutary health behaviors, in our case, dietary and hygienic. Because as pediatric dentists, we deal very significantly with a disease, dental caries, and because that disease is very much dietary in its determinants, another support professional with whom we could work closely are dietitians, nutritionists. Nutritionists, like health educators and like social workers, help people address the opportunities as well as the barriers to assuming positive oral health behaviors, and in our case, dietary behaviors. For more information on the roles of clinical nutritionists in pediatric dentistry specifically, we welcome you to visit a web page and view a video at the links provided on this slide. Unlike social workers, behavioral nutritionists, and health educators, who are formally trained and regarded as professionals, community health workers are lay health workers, often identified by their own communities for the support that they are able to provide to others in their community in negotiating health and healthcare systems. A community health worker is therefore very much a frontline public health worker. The community health worker brings no clinical skills to the patient, but does bring social skills and tremendous knowledge of the local environment in which people seek to adopt and adapt their behaviors. At Columbia University, with support from the Federal Centers for Medicare and Medicaid Innovation, we fielded 13 community health workers with over 1,200 families, to all of whom have children with early childhood caries, and provided support to these community health workers with informational technology called the My Smile Buddy app. These community health workers were able to help people over time identify risky behaviors that led to their children having early childhood caries and make behavioral change. As health systems move toward value-based care, they are increasingly realizing the strong potential to engage community health workers. In fact, the U.S. Bureau of Labor Statistics suggests that over the next 10 years, the field of community health workers will grow dramatically with a growth rate of 20%, nearly 20%. This slide details a list of 24 roles for community health workers that have been defined and describe the range of things that trusted, non-professional lay health workers can bring to their communities. When pediatric dentists recognize the value of engaging support professionals and community health workers, the next question becomes, well, how do we engage them, especially since adding more people to our staff for engagement with select patients is not cost effective. So one way to do so is through referral, identifying resources in your community for referral to social workers, health educators, clinical nutritionists, community dental health coordinators, and community health workers. Another available to large groups is to hire these support professionals or some subset of these support professionals to be available to the practitioners in the group. And then a more likely scenario is that dental support organizations or dental management organizations, which tend to aggregate much larger networks of dental providers, are in a potentially more beneficial position to hire these support professionals and lay health workers and provide access to them for their member dentists.